Geoff Joyce from USC.
Thank you. I'm going to touch on some of the points John raised earlier and Suzanne as well, talking about the drivers of healthcare and then some possible solutions, or maybe one broad solution, one of many. You've seen these types of plots today and probably in other contexts. Healthcare spending is rising as a share of our economy. And if I showed you that trend in semiconductors or cell phones, growth in spending in and of itself is not necessarily a bad thing. The question is, are we getting value for the money we spend? And the question is, when we look at the public share, the federal government pays about half of healthcare spending overall. It's larger than healthcare. It becomes more of a public finance issue as well. Can we afford sort of growth in healthcare spending that's far greater than what we see in growth in the economy? And I think the point being here is if you look at our overall growth in healthcare spending relative to our economy, that there are consequences. But this has been fairly linear. Despite changes in prospective payment and growth in managed care, this growth in healthcare spending has been fairly monotonic or consistent over a long period of time. And Joe Newhouse is a prominent health economist. Over 20 years ago, he wrote an article, What's Been Driving Healthcare Costs? Let's break down the components. And I think, again, what's important is not the level of healthcare spending, but the rate of change. And from 1950 to about 2000, costs went up by about 600% or 4% real, which means above the rate of inflation. So what are the possible explanations? Well, demographics are one. As people age on the sort of the horizontal axis, they spend more on healthcare. And as medical care has gotten better, as sanitation, public health has gotten better, people live longer. That's all good. But we are going to spend more simply because of demographic changes. So as more and more people live into 80s and 90s, we will spend more per capita. That's okay. And if you look at other countries, so this breaks down the growth. This was projections from the IMF of growth in healthcare spending per capita for the next 20 years, from 2010 to 2030. And obviously the US is at the far left of the scale, about 5% growth. And you see a sort of comparison, mostly European countries here. But I think everyone, the red bar represents the demographic aspects. So what fraction of health growth in healthcare spending is just driven by an aging population? Most countries are facing similar type things. You see Japan and Germany, it's almost all driven by demographics. So they're basically per capita is flat rate of healthcare growth. And that's what we worry about is this gray portion, which we consider the excess growth in healthcare. Second reason we've seen expansion in spending over the past 50, 60, actually 70 years now is more generous insurance. If you look pre-Medicare and Medicaid in 1960, 55 cents on the dollar roughly was spent out of pocket. So back in 1960, if you went and got medical care services, you paid more than half the bill out of pocket. Today we're at 13%. So clearly, if you lower the price of any product, as we're lowering the price of medical care, we will consume more. And we have lots of evidence from natural experiments and other types of randomized experiments about how much of the growth in spending is due to more generous insurance. Many would say that's good. Clearly, having seniors and the poor having health insurance is a good thing, but it clearly has driven up growth in spending. Third reason is wealth. We've gotten richer, and there are only so many flat screen TVs you can buy and cars. And what we see are, if you look at all comparison countries, they tend to be on this close to 45-degree line, meaning as they get richer, per capita income increases, spending on healthcare increases. Luxembourg's a bit of an outlier because they have funny banking laws, but the US is a big outlier off this line. So yes, we do spend more because we are one of the wealthiest countries in the world, and we're spending more on healthcare. And in and of itself, that's not so bad, but again, it does seem like we spend a lot more per capita. And the question is, are we getting bang for the buck or value relative to our comparison countries? So if you just look at Newhouse sort of summarized it, and this extends to today, you can break up the growth in healthcare spending into demographics, which there's not much we can do about, growth in income or wealth, which in many ways is a good thing, as is the growth of insurance. And then maybe there's some small part for prices. Prices in healthcare are hard to measure. Like think about laptops or computers or phones. The technology has improved so much, it's hard to measure what the value of a laptop today is probably that has the power of a mainframe 20 years ago. But in general, we think what is left is that residual is technology. and our access to that technology, which is largely unfettered in the US relative to comparison countries. And it's not necessarily a bad thing, but if you just look, and these are older data, if you look at hospitalizations per 1,000 members, it's per 1,000 population declined, average length of stays declined. So the days per 1,000 are falling significantly, but the cost per day in a hospital has increased. And Suzanne mentioned earlier, when we talk about spending on healthcare, it's price times quantity. And quantity in the US is not that out of line with most of our comparison countries. Physician visits per 1,000, hospitalization rates are actually lower, length of stay is shorter, but our prices are substantially higher than in comparison countries. Okay, probably the best slide I can show you today. On average, though, spending it seems to be worth it. Here are mortality curves. So here's the number of deaths per 1,000 population, and you can clearly see the deaths rise as people age. That's 1974 mortality in the US, 1984, 1994, and 2004. And so when people talk about, oh, 65 is the new 55, or whatever it might be, the data say, you know what, that's true. We've gained over 7 years of life expectancy in a relatively short period of time. So yes, we do spend a lot, but there are seen to be payoffs. Now the bad news of this is the European countries and other comparison countries have also seen these gains in life expectancy, and they spend 30, 50, even 100% less per capita than we do. Okay? So we know there's some inefficiencies, but there clearly has been some value to what we've been spending. You'll hear talk today from very good research. We've done some at Schaefer Center at USC on all of these issues of way to control spending. Payment reform, obviously, we're talking about bundled or episode-based payments. If we change the incentives, pay per performance or value-based payments, particularly in pharmaceuticals. There's all sorts of talk today, justifiably, on how do we make healthcare more affordable. We want ACOs and integration, so there's coordination of care, but at the same time, that leads to provider consolidation and therefore less competition. Clearly, care coordination is a big issue. Patient-centered medical homes are the topic du jour of how we have better integrated care. We need to regulate insurance markets. There's all sorts of smart and not so smart things that have been talked about in recent years about insurance reform. And then we're talking about capping federal liability on healthcare spending, reference pricing, which Jamie will talk about, price negotiations on drugs. All of these are important, and I think they can affect and reduce growth in healthcare spending, but they are somewhat small and incremental. And I think one thing we've been having more discussions is thinking more broader about how can we address more than just, as Suzanne said, if you squeeze the balloon in one area, it tends to inflate in another. How can we think more broadly about healthcare reform? And I just try and mostly educational to students think about, we believe in providing access to healthcare in most developed countries, but it costs money. And there are potentially efficiency-reducing trade-offs in healthcare. And so how do we balance these goals of providing access to affordable, universal coverage while maintaining efficiency? And we tend to have three aims in healthcare: improve public health, equity and fairness, that more people are covered, and have some efficiency so we don't overtax people and basically reduce wealth. But trying to move closer to one of these goals tends to have trade-offs. It's very hard to think of ways where we can improve health, improve equity and fairness and wealth at the same time. So a policy that combats adverse selection and increases fairness in healthcare markets, like the Affordable Care Act, could increase costs or lower health for some groups. And furthermore, there's a lack of consensus. What's the right approach on the relative importance of these goals? Some value equity, that everyone should have access. In most developed countries, having uninsured rate below 1% is unacceptable. Prior to the ACA, we were at 16% uninsured. And some are willing to pay more in taxes to achieve that type of equity. Others place higher value on health, and they're willing to tolerate some monopoly pricing or some moral hazard in response. One thing we've talked about is sort of what are the 5 aims we might want? Well, we'd want coverage that was universal and progressive, build on but don't replace the private health insurance system. I think that's really important as far as a political feasibility. Keep it affordable and sustainable. Reduce incentives for adverse selection so we don't cherry pick. And create incentives for prevention and long-term investment. And things we've been talking about at Schaefer broadly are means-tested catastrophic coverage. Would meet a lot of these aims, It's not the only solution, but again, it has many, many attributes. So we proposed take everyone who's not in public program today, anyone who's not in Medicaid, Medicare, or some public program, offer identical high deductible health insurance policy from a private insurer contracted through the federal government. Have it be 3-year contracts minimum. Over time, I think we'd hope we'd get maybe into 5-year contracts. So there's some stability. Deductibles would vary. So you can have a high deductible plan, but it's going to vary as a function of your income. And even those who were means tested could get premium support. So you'd subsidize both deductible and premium. It reduces the incentives for adverse selection. You'd basically have a fully insured population. And we get rid of the need for this web of federal and state regulations that we have today. For example, guaranteed income, issue, community rating, mandates, portability, exchange functionality. All of these things would go away. It would encourage long-term investments in health. Private insurers would be required to offer multi-year coverage. And innovations that save money would be exempt from the deductible. That's what the ACA did. There were 6 preventive services that were excluded from cost sharing. There are easy ways to say if we think, for example, statins for patients with heart disease are cost effective, they could be exempt from the deductible. A former RAND graduate student just did some simulation modeling on what a catastrophic insurance premium might look like and what it would cost. Her estimate was, I think it was $3,350 premium. It would cost no more than the ACA did today. It would cover 15 million additional people. So again, this is just one area I think we talk about when we think about broad changes of universal insurance protects everyone from catastrophic loss, which is what insurance is designed to do. It's not designed to pay for small stuff, but big stuff, and removes the incentives for insurers to avoid bad risk. You get a mean tested deductibles and premiums, so it's progressive. It's quite affordable. Again, premiums would be 40% lower than, let's say, the ACA Silver Plan. Multi-year contracts would encourage long-term investments and modest cost to taxpayers. Again, the simulation modeling done at RAND estimates it would cost less than the ACA and still insure more people. So it's a quick introduction. We can have talks later. Okay.
Well, first I want to give you credit for putting forward a plan, and next I want to play devil's advocate.
Okay.
Because isn't it true that today more and more people are already in high deductible plans? And so aren't they de facto asked to buy catastrophic coverage through the exchanges already?
Well, you know, Cover California actually went the other way,
right.
and they had right. very low deductibles. And I think, you know, you could make an argument for one way or the other. I think we do worry that sometimes people don't make good healthcare decisions. So if people did have a deductible of $3,000, $4,000, $5,000, the fear is they would forego cost-effective care right. because it's coming out of their pocket.
Right.
I think we can mitigate some of those concerns through education, through sort of carving out services that we think are extremely cost-effective, carving those out from the deductible. But again, I think generally speaking, if you protect low-income folks, most of us can afford a $4,000, $5,000, $6,000 deductible, and I think would make us better consumers of healthcare. And with proper benefit design, I think you can mitigate some of these concerns.
I'm not sure really how many people really have $4,000 or $5,000 that they could use for an unexpected medical event. I think there's a lot of evidence that more people than we'd like to admit don't have that.
No, and not to get into the details of this, but this right. we simulated this at that you would pay no more than 10% of your disposable income, which is income above the federal poverty line. But again, I do think there would be some savings, obviously, okay. in other types of funding of the healthcare system that would make this cost effective.
So the key question is savings to whom? One final point is politics. I've been around a while, so I lived through Medicare catastrophic. And we forget that Ronald Reagan signed into law yeah. A Medicare benefit to add catastrophic coverage, which I certainly did my utmost to support. And it was repealed a year later. And I think it's fair to say that there was very little public understanding or support for the need for catastrophic coverage. So I think that's a a real barrier to this idea.
No, and particularly you take a Medicare population that did have sort of
Right.
a very generous package, and you tell them we're restricting your benefits. I think the world has changed. Our healthcare system has changed. Instead of 10% of GDP, we're at 18% of GDP. I think the dysfunction in our healthcare system is a little more clearer to everyone in the country, and I think we're more sophisticated and educated about our healthcare system and its flaws. So I do think, and again, I do think for most people outside of Medicare and Medicaid, this would not be as punitive or as a sort of a step down in healthcare coverage as it was for Medicare.
Okay. Thank you, Jeff, very much.
Sure.
And please join me in thanking Jeff.